Hi everyone, it's Dr. Custer here. Today we're going to talk about Journal Club. We'll talk about study design and comparing groups. So let's get started. My disclaimers. You guys all know I'm not a statistician and this video is for educational use and it's not intended to be sold. So this is kind of a lengthy one. Here's the goals of what we'll go over today. First thing is we'll review the steps to evaluate medical literature, and this includes study design and basic statistical analysis, and we'll just do a brief review of comparing groups and regression modeling. Then we'll go through some Journal Club tips and, of course, wrap it up with some example problems so you guys can apply what you've learned. All right, so let's get into it. How to evaluate medical literature. A lot of this comes from the MSU's SCS website, so if you guys need additional help, that's where I would turn next. As we reviewed, the 7 basic items to look for. First, of course, defining the problem. Second is the definition of the variables being analyzed. Next, specifying the research question and assessing the selection of subjects. Then you want to identify what research design was used and assess whether it was appropriate. Then we'll talk about analyzing data and assessing interpretation of the results. Now, please note that not all articles have all of these 7 elements, but when we talk about original research, that's what we're looking for. All right, so let's move on. So the first step when you're looking at an article is defining the problem. So why was the research important and why was it needed? This is usually at the beginning of the article. You guys all know it's either a statement or statements that guide the research question and hypothesis. And like I just said, it supports why the research is important and needed. And it specifies the particular aspects of the problem to be investigated. So this is how you know narrowly what were they looking for. And here I give an example of a low-dose aspirin preeclampsia study. And here in the background at the beginning of the article, you can see the statement of needs. So, you can see here that there's variation in the guidelines and that the previous studies have focused on other populations. So that is the definition of the problem. Next, you want to define the variables that are being studied. Now, let's just remember the independent variable is the one being manipulated by the researcher. So I'm going to give you guys an example of putting people on diets. So independent, if you had different kinds of diets, the independent variable would be the type of diet. Dependent is what is impacted by the independent, of course. And so for a diet plan, it would be the subject's weight. Now, we also talk about confounding variables. And these are different variables that may affect the dependent. And so in the case of losing weight, you can see the weight of the clothing could be a confounding variable. So what do? You control for it. You weigh each subject naked. And that's just a very basic review of independent, dependent, and confounding variables. So here we are in our low-dose aspirin study, of course. The independent variable is the low-dose aspirin, and the dependent variable in this case was the occurrence of preeclampsia, and then they took a look at several biomarkers. Potential confounders in this study was patient BMI and tobacco use. So you can see how those could impact the occurrence. And that's why, in this case, you have inclusion-exclusion criteria. So you exclude patients that are using tobacco potentially to reduce that. All right, next we talk about specification of the research question. Oh, yes, you guys know I love my definitions. So a research question is the fundamental core of a research project, study, or review of literature. It focuses the study, determines the methodology, and guides all stages of inquiry, analysis, and reporting. So this is a very fancy definition of research question. There's 4 main types of clinical questions. The first one is therapy. So these are questions, research questions concerning the effectiveness of a treatment or a preventive measure. Next, we have the harm and etiology type questions, which are questions concerning the likelihood of a therapeutic intervention to cause harm. Diagnosis questions concerning the ability of a test to predict the likelihood of a disease, so how well does it diagnose? And then prognosis type questions concern the future course of a patient with a particular condition. So these are the 4 general types. Now, the usual focus of the research question is the effect that manipulating the independent variable will have upon the dependent variable. And this is typically found at the beginning of the article. So it's important to be able to identify and specify what the research question is. And here from our preeclampsia article, we see the following hypothesis will be tested. The administration of low-dose aspirin to pregnant women will reduce the occurrence by 20%. So you see a specification of our hypothesis there. And then now we move on to selection of research subjects. So when you're looking at an article, it's important to determine the adequacy of the subjects that they were selected for. Are they representative of the population of interest? Was it randomly selected or randomly allocated? Sometimes it's impossible to randomly select, but you can comment if the groups were allocated randomly. Then you take a look at the inclusion and exclusion criteria when you're looking at the subject sample. So are they reasonable? Another thing to take a look at is sample size. So as you guys know, generally the larger the sample size is, the more likely it is that you can trust the results as long as they're representative of the population of interest. And of course, the smaller sample, it's less likely to trust the results. Of course, these are not hard and fast rules. All right. My computer's acting wacky. Also, it's important to note if authors included a power analysis for the study. So remember, power is a measure of the probability that a difference will be found if it really exists, in fact. And so, for example, in our preeclampsia article, you can see they included a sample size calculation, and there is a consideration for 80% power with a typically used acceptance of 0.05. You can see what they needed in each group, so that's important to note. All right, identification of research design. So most study designs fall into 2 categories, and these are the non-interventional or observational study designs and the interventional or experimental designs. We're going to go through each one. And remember, when you're looking at the Journal Club article, it's important to assess if the design is appropriate. All right, now this is a crazy slide, I realize, but if you look, you can see that there's non-interventional or observational studies here, and then there's interventional studies here. So it's just kind of breaking it down. And of course, we have our quantitative and qualitative. So looking at observational studies, the things we talk about the most are case reports, case series, cohort, and cross-sectional studies. So these are looking at individuals as a unit, and then ecological correlation research is looking at the population as a unit. That's the only difference. And you can see that observational studies can be descriptives, where they're just looking at frequencies, or they can be analytic, where they're looking for relationships between factors. And then here we have our interventional studies, which of course are experimental. We're used to our randomized controlled trials, whatnot. And then our quasi-experimental studies, which aren't randomized, which we do quite a bit with our pre-post type research. So let's go through all of this. First, the non-interventional or observational study design. These are descriptive studies. They describe naturally occurring phenomenon. They also can demonstrate associations or relationships. Like I said in the previous slide, the correlational study describes observations at a population level. One limitation of this is there is potential for erroneous conclusions. Case report and series, they usually describe unusual cases, which may provide a greater understanding of the disease. So there's a lot of value in our case report and case series. Next, we'll just briefly go through analytic studies. These outline disease distribution in a population. Now remember, these do not address causality. You can do correlation, not causation. So case control studies, these compare patients who have a disease or outcome of interest, i.e. the cases, with patients who do not have them, which are the controls, of course, to determine the odds of the disease. Now, this is a retrospective study design. It is easier to organize and conduct than cohort studies, which are prospective in nature, but you must choose your controls properly. Case control studies are good for small outbreaks of infectious disease and other things like Reye syndrome, which is a rare disease, hepatitis A kind of outbreak. You'd want to see where the exposure came from. And of course, measures our odds ratio and case control. Cohort studies, on the other hand, these investigate the causes of disease and establish links between risk factors and health outcomes. These are prospective. They follow groups over time to see if the disease of interest occurs. They're designed to describe the risk of a disease directly. One example of a cohort study is the Framingham Heart Study. Now, you guys remember this identified risk factors for coronary vascular disease as high cholesterol, diabetes, tobacco use, and hypertension. So very important cohort study. Remember, longitudinal means following over time. And in the cohort studies, we determine relative risk. All right, cross-sectional studies. Lots of resident projects love cross-sectionals and survey studies. So generally, these use surveys to compare an exposure and outcome at the same time. Think of it as a snapshot look at a particular time. Otherwise known as prevalence study. Potentially advantages, they are cheap and easy to perform surveys. Disadvantage of the cross-sectional study is you can't always be sure of the temporal relationship between your exposure and outcome. So you know you have an exposure, you know you have an outcome, but you don't necessarily know how that temporally took place. Cross-sectional studies there's descriptive, which will look at frequency and distribution of whatever you're looking at, or analytic, where you're investigating the association between the two parameters. So here's a pretty decent chart. If you think about it, just is there an assigned intervention? If it's yes, then you have an experimental study. And then these are just the two kind of allocations. Over here we see observational study. Is there a comparison group? If not, that's just descriptive. If yes, then you have to look at the direction of the exposure in the study. If the exposure came first and they're following the outcome over time, then you have a prospective cohort study. If they have the outcome first and they go back to look for the exposure, that's a case control. And then, of course, exposure and outcome at the same time is your cross-sectional study. All right, so we'll go through each type individually. A little bit more experimental design. We have the randomized controlled trials. We'll do a brief introduction to that today, but there's plenty more detail in the Understanding Clinical Trials module that you guys do. And then, of course, our quasi-experimental designs. So randomized controlled trial is the most effective way to determine whether a cause and effect relationship exists between an exposure and an outcome, like we've said. So exposure is assigned to study subjects and followed over time to determine the outcome or endpoint. And remember, with randomized controlled trials, our endpoint is defined at the beginning of the study. So whether it's mortality rate, hospitalization rate, complications, etc. So the main features to be familiar with for RCTs are randomization, blinding, and intention to treat. So randomization is the process of assigning participants to treatment and control groups. It's determined by chance. There's multiple ways to randomize. I'm not really going to get into all of them, but the goal is to create groups with similar distributions of known and unknown variables. And this, of course, will minimize our effect of confounding factors. And it also can eliminate susceptibility bias, which you guys remember is assigning to a group based on severity of disease. Blinding is the next topic. Blinding, you guys know, the exposure status is kept from the patient and or the investigator. If it's single-blinded, the patients are blinded, and this will minimize your placebo effect. If it's double-blinded, your patient and your investigator are both blinded, and this just decreases observer bias, where a caregiver might misclassify outcomes. The last thing is intention to treat, which just means that all randomized participants are analyzed in their randomized group. Regardless of whether they continue in that group, that kind of ignores noncompliance, protocol deviations, withdrawals, etc. And it reduces confounding due to non-random dropout and noncompliance. So that's intention to treat. The opposite of that is, of course, as treated. It's just the way it's analyzed. If it's as treated, the subject's data is analyzed in the group they ended up in, and that's all it is. All right, let's go through some quasi-experimental design. There's a bunch of different types of these, but one is the non-equivalent control group. So the subjects are intentionally assigned to groups. For example, if you had a high school curriculum, an alternate curriculum you wanted to test, and you had a whole hallway full of classrooms, and you assign different classrooms to have just the usual or the alternative curriculum in one, that would be an example of non-equivalent control group. Pre-test, post-test is very, very familiar to all of us. This is exposing all the subjects to the treatment or stimulus or the intervention. So the comparison comes from examining the subject's responses to the outcome of interest prior to and after the exposure, so pre-test, post-test. Time series is another type of quasi-experimental design where you're observing a group repeatedly before and after a treatment, so multiple time points. All right, so after study design, we have to analyze our data. So analysis of data is just assessing if the appropriate test was used for the type of data collected. And we'll talk a lot about this. Parametric versus non-parametric test is the first thing we'll look at. Of course, parametric tests assume normal distribution. Remember our bell curve. This has homogeneous variance, and of course, we're talking about mean and standard deviation because we're talking about bell curves. And in that, we look at t-test and ANOVA. Non-parametric don't particularly follow any distribution. The variance can be varied. We're looking more at median, and this is more of our chi-squared or Fisher exact. So what does that all mean? Let's get into it. Oh, of course, we're going to go through our types of variables. Everyone loves this: nominal, ordinal, interval, and ratio. This chart's kind of scary to me, so I just go to the next one, an easier way. So is the variable a number or is it a word? So numeric is number, and then we have our continuous, discrete, and then categorical are qualitative or words, which are ordinal and nominal. So of course, nominal, it's a qualitative variable, and its values cannot be ranked. And an example of this is gender, if you have male, female, other, etc. An ordinal variable is also a qualitative word, but the values can be ranked. And so you see here aggression, which is weak, moderate, strong intensity. Another example would be perhaps education level, where you have high school, diploma, bachelor degree, master degree, etc. Intervals. So here we get into our numericals. Interval is just the value of the variables can be ranked, and the difference shows the difference between the values. So there's no 0 point. So we talk about temperature. And then ratio is the values can be ranked, but also there's a true 0 point. So one thing we think about, of course, is height. And we look at this continuous versus discrete. Discrete is something you can count, and continuous is something you can measure. So these are basically the 4 variables. Oh, and there's our cheat guide everyone can look at. Okay, so comparing groups. When you have to compare variables, you want to look at it and say, okay, are these means or are these proportions that we're looking at? Are they categorical? Are they qualitative? Or are they numeric? If they're means, then you look at your samples. Are they 2 independent samples, or is it the same individual followed over time? If we're comparing 2 groups of means that are independent, then we have to look at, is it 2 groups or more than 2 groups? 2 groups, you're going to do your t-test. That's your student t-test. More than 2 groups, you're looking at analysis of variance. Now, if you're looking at the same individual's results over time, then you can do a paired t-test, which just means they're from the same individual. Now, proportions, if the sample size is larger, we're going to look at chi-squared, and if it's smaller, it's just Fisher's exact test. So let's keep going. So looking at parametric data, which remember is our mean, is our bell curve. We just talked about the student t-test, which compares the means of 2 independent groups. So we're looking at means, sample variances, and sample size. ANOVA is the analysis of variance, which just compares means of 3 or more independent groups. So this is looking at, obviously, more than 2. The paired t-test compares the means of 2 dependent groups, like we just talked about in the last slide, looking at results from the same subject over time. All right, so here's an example of a paired t-test. You can see female and male. They looked at the self-concept. This was related to STEM education and whether or not they would see themselves going into a STEM career after a STEM intervention. So in the female group, you can see that there was a significant increase in the STEM interest and concept post-intervention for both groups. Male, however, you see there is no significant. Now remember, significant is a p-value less than 0.05. So that's one. All right, so now we move on to non-parametric data, talking about chi-squared, which is used to compare proportions of a categorized outcome. So for example, if you have a study that has categories of C-reactive protein as high or normal, and then you're looking at those to the outcomes of hormone replacement therapy or non-hormone replacement therapy, those are proportions of numbers that you're going to compare. So the chi-squared is a goodness of fit test looking at the observed values to those that are expected if the null is true. So chi-squared, we talk about what was expected if the null is true versus what was observed. And if the difference in the observed and expected is large, then you assume that there's an association, a significant association present. Fisher exact test is very similar, but it's a smaller sample size. So here's an example of observed versus expected. Here again, we see male and female, but the expected frequency that the shoes were worn or made or however this was here. You can see in both groups, they expected 9.5 sandals, 11 sneakers, 10 shoes, etc. Now we look at the observed values, and you can see in men there were less sandals. In female, there's more sandals. So these are just what they observed versus what they expected, which was already determined. All right, we're looking at sample characteristics. This is when your chi-squared test comes into hand. You guys see this for demographics in every study. We're looking in this one, looking at alive versus dead population by survival status. And so we look at something that's significant here. We look at gender. We see our p-values less than 0.0001. For the female group, there's significantly higher females, in the alive group, there's significantly higher number of females than males. Then in the dead group, there's a significantly higher number of males and females, and the difference was significant, as you can see by your 0.001. So this is just an example. Here's another demographic table. This is exactly the same. We're talking about gender. Here you can see in the treatment group, there was significantly higher number of women than men, and that's just another example. All right, let's go over regression modeling. So this is predictive analyses. The dependent variable is the main factor that you're trying to understand or predict. So one example let's talk about is primary care compliance. The independent variables for regression modeling are the factors that you suspect might have an impact on your dependent, and you're looking for that association. For this example, you could think of things like social determinants, such as transportation, economic status, or health literacy level, other things, gender, age. How do these factors all affect the dependent variable or the outcome of interest? And you'll hear a lot of different words, linear, logistic, stepwise. It's pretty much all the same thing. It's all looking at the line of best fit. So here's an example of regression modeling. You guys don't have to try to interpret this at all. All I'm showing here is that the dependent variable or the outcome of interest that they're looking at is the perceived ease of use, usefulness, and attitudes towards using. I'm not even sure what they're talking about using, but here we see independent variables, and they looked at age, gender, co-resident, education level, marital status, work status. So you can see how they're, in this regression model, they're looking at how do these independent variables predict these outcomes. Here's a clinical example, and I apologize the poor quality of this. Here we see they're looking at, they were looking at bowel perforation cases, and they looked at these kind of factors to see if they were predictive of the bowel perf. And it's interesting because you can see here through your p-values, none of this is significant, but then when we come down to here, we see a significant result, and it's bowel obstruction. So that kind of makes sense that having an obstruction would be a predictive factor of having a perforation. All right, so after you look at the results, you have to interpret them, right? So how do they interpret the results? These are the questions you should ask. Are the conclusions they come up with warranted by the data? Are they supported by the data? Are they consistent with the data? Did the author draw reasonable conclusions? Are they generalizable, the results? Are they of practical importance? Are they useful to you? So these questions, it's important really to look at, are these results generalizable to your patient population? It may be that parts of the study population are similar to yours, and then maybe it would be more practically important, but these are things we'll talk about. Other factors to consider, was there a consideration of confounding variables and how to control for them? If the study was set up where there were a ton of confounding variables and there was no mention of them and how they impacted the final results, that might be a weaker kind of study. And then, of course, we have the statistical significance versus practical significance. So it's really important, like I said in the last slide, when you're looking at something that has a p-value of 0.0001, it may be statistically significant, but is it applicable to your practice? It's something to consider. If an actual difference between treatments is not very large, it may not be clinically significant unless a new treatment comes out that's more cost-effective or safer, of course. So will it change your practice? So developing a good journal club, some tips. Avoid restaurants or other noisy places. Everyone laughs when I say this. But it's important that you can hear and engage in discussion actively so you can learn from journal club. It's important to meet regularly. It's recommended at least monthly. Use a checklist or other rubric to prepare or evaluate your presentation. We have a couple of them floating around now, so I'll make sure everyone gets those. There is a journal club form available on New Innovations, and that's the form that the SCS uses. Making sure everyone comes prepared. I get it that there's always one person inpatient that's been on call Q3, but everyone else should have read the articles and have some general understanding of what the article obviously says. Accountability is a huge factor. And then for each article, it's recommended that you present for 8 to 10 minutes, and then there's 10 to 12 minutes of discussion with either senior residents or an attending physician, or both. And of course, making sure that everyone can attend that can attend, and so whether or not it's mandatory. And here's the journal club checklist from the SCS website. And here's the 7 basic items to check when assessing research literature, and those are the things we went through in this lecture. And then there's this list of evaluation questions. So both if you're presenting or if you're preparing to evaluate a presenter, these are things that you can look at. All right, we're going to go on to just a few problems, and then we're done with the lecture. So the first one, an investigator suspects that acetaminophen use during the first trimester can cause neural tube defects. He estimates that the general population risk of having neural tube defect is 1 in 1,000. Which of the following is the best study designed to investigate the hypothesis? And we talked about these. So this is a rare condition. And so the best thing to do is case control. Remember, looking at, so you have your outcomes, and then you're going to go back and look at your exposures. All right, the next one. A group of investigators are studying the relationship between a particular 5-lipoxygenase genotype and atherosclerosis. A study population is randomly selected. Blood samples are obtained for leukocyte genotyping, and ultrasonography is performed to assess carotid intermedia thickness, a marker of atherosclerosis. It is then concluded that the particular 5-lipoxygenase is associated with a predisposition to atherosclerosis. Which of the following choices identifies the study design used by the investigators? All right, so we have these 5 answers. So what do we have going on in this? So they have a study population that they randomly selected. They took blood of this population for a leukocyte genotyping, and then they did ultrasonography to assess carotid intima media thickness. So we're looking at an exposure, which is the leukocyte genotyping, and we're looking at an outcome, which is the carotid intima media thickness, or the atherosclerosis, of course. So what kind of design would this be? This would be a cross-sectional study. Remember, looking at an exposure and an outcome at the same time. All right. 500 women aged 40 to 54 who present for routine checkups are asked about their meat consumption. 20% of the women turn out to be vegetarian. During the following 5 years, 5 vegetarians and 43 non-vegetarians develop colorectal cancer. So what kind of study design are we looking at? We have a group of women, And in this group, 20% are vegetarian. So we follow them out prospectively, and we see how many of the vegetarians developed colorectal versus how many of the non-vegetarians. So we have 2 cohorts that we're following prospectively. So which of the following best describes the study design? The cohort study, right? All right, I'm going to try to read this big words. All right, pancreaticoduodenectomy, that might not have been right, is a procedure that is associated with considerable morbidity. A study was conducted on 553 patients who had a successful PD to determine whether their surgical APGAR score is related to 30-day perioperative morbidity and mortality. The table below gives the number of patients experiencing no, minor, or major morbidity by SAS category. All right, so we have 3 categories of surgical APGAR scores: 0 to 4, 5 to 6, 7 to 10, no morbidity, minor morbidity, or major morbidity or mortality. What would be an appropriate statistical test to examine whether there is an association between surgical APGAR score and patient outcome? All right, so we have 3 categories of scores and we have 3 categories of outcomes. So what are we looking at? We're looking at chi-squared. Remember, chi-squared compares categorical proportions. All right. A randomized double-blind clinical trial is conducted to evaluate the effect of a new drug on the survival of patients after PTCA. 1,000 patients undergoing PTCA are randomly assigned to the drug or placebo, 500 in each group, and then followed for 3 years for the development of ACS. Severe acute myositis is a rare side effect of the drug therapy, but the difference between the 2 groups in the occurrence of the side effect is not statistically significant, p equals 0.09. Now, the same side effect was reported in several small clinical trials of this drug. So the question is, the failure to detect statistically significant difference in the occurrence of acute myositis between the treatment and placebo groups is most likely due to what? So it's nearly significant, right? Why are we not getting to statistical significance in this case? And it's small sample size. So we have several small clinical trials, it says right here. We have near significance in this larger trial, but really the small sample size is why they're not seeing that. Now, the researchers want to further investigate the association between the new drug and the occurrence of severe myositis. They note that several other studies have reported the side effect, but none of these studies demonstrated a statistically significant difference in the rates of severe myositis between the treatment and placebo groups. So, in this case, what would be the best method to investigate a possible association between the drug and the development of the interaction or the complication? And so we have these choices. Should we conduct a new, larger trial and try over? Should we look through the charts again, do a stratified analysis? Should we pool the data from several trials? Or do we just ignore everything? In this case, remember, when we have a lot of smaller trials with data, we can actually pool it together and then see if we have a statistically significant association between the drug and the development of severe myositis. All right, we're almost done with the questions. A psychiatry resident is interested in comparing the effectiveness of different types of therapy in his patient population to see if one therapy is better than the other. He compares PHQ-9 results of a group of psychiatric patients who are trying 3 different therapies: counseling, medication, and biofeedback. So the question is, what would be an appropriate statistical test to examine whether one type of therapy is more effective than the others? So he's looking at the mean PHQ-9 results in 3 different groups, actually. One's receiving counseling, one's receiving medication, and one's receiving biofeedback. So if we have 3 groups that we need to compare, remember, we're talking about analysis of variance, so comparing the means of 3 or more groups. All right, so in summary, evaluating medical literature is a skill you will practice and become proficient in during residency. And it's very, very important to prepare for journal club, whether you're presenting or you're just listening, or you have to know the material to get the most out of it, right? So understanding study design and how to interpret data analysis and results will ensure that you can critically evaluate what you read throughout your career. And that is the whole point of residency, learning what you need to know. So thank you for listening. If you guys have any questions, you can email me, you can text me. After this, you can go back to the new innovations, get the link to the SurveyMonkey quiz, and take that. All right, thanks.